I'm setting up. Hope my camera doesn't fall. All right, I'm here live. I'm here to answer any questions that you might have if you're an occupational therapist assistant, if you are a student and you're going into field work. I've seen a lot of those posts recently about, what do I need to prepare for, that kind of stuff. And then what else have I also heard? I've also heard a couple of questions. Oh, I'm going to share with you something that I went over with my own therapist today, talking about fractures of the distal phalanx, right? So, oh gosh, I have a hangnail. Anyway, so I just wanted to come on and answer a couple of questions that you guys might have. So if you come on, then just go ahead and type some questions and let me know anything that you want to know. I am here for you. Anything as it pertains to hand therapy, of course. So recently I've heard a couple of people ask on different sites and stuff like that, this one question where you're still in OT school and you're going into field work, like, what do you need to know? This is what I tell my students. Like, so when we take students that are coming into field work, we don't really expect them to know like a ton. And it's because hand therapy is it's a specialty area. So I mean, it's so difficult to know everything and to know exactly what to do for everything. I mean, as I am creating foundations of hand therapy, and I did some videos and stuff like that over the weekend, and I taught this like a month ago as well. I mean, there are so many little things. And as a student, I would just encourage you to, and this is what I tell my students as well, I would encourage you to go through and look up your anatomy. Like, do you need to know it the same way you know, like when you're getting tested in school and like the exact pinpoint area of an organ insertion? Like, you don't need to know it in that sense, but you need to know, okay, this is my humerus, this is my radius, this is my ulna. And I always ask this question, and I kind of like to teach my students about it. But I'm like, what are the 3 bones that make up your elbow, And if you know your anatomy, you're going to know the 3 bones that make up your elbow, that type of stuff. So you want to know in general as much as you can in terms of anatomy, know some major muscles, like what are some really common injuries that we tend to see in the hand therapy world. Distal radius fractures are one of them. I mean, do you need to know everything? You just need to know, okay, like, that bone gets fractured and someone might come in and they had surgery or they didn't have surgery. And I wouldn't expect my students to know everything. I would expect them to know general anatomy. And then sometimes I encourage them, once they come in, depending on what our cases are looking like, then I'll encourage them to go ahead and go home and read on certain cases. So if we have a new radius fracture or we have a rotator cuff repair, that type of stuff, and then they're just going to build on their knowledge. But if you're an occupational therapist student and you're doing a field work affiliation, just try to know as much of your anatomy as possible, whether it be bones, some muscles, that kind of stuff, and maybe some common injuries. But you're coming into the field work so that you can get trained, and you want to know basic evaluation skills, right? But you're not expected to know everything, and your clinical instructor should be the one teaching you what that particular setting is and how they do certain things, how they do an evaluation, how they write their notes, how they treat, and that kind of stuff. Some hands-on, some splinting, so I would encourage that if you are a student going into a field work affiliation. I am outside my house right now. Mailman's coming. I'm not getting a package, unfortunately. But anyway, so what's another question that I had? So I wanted to share with you the difference between a lag and a contracture of the DIP. So we had a patient come in and the diagnosis is a mallet finger. Now, a mallet finger is when you maybe jam your finger somehow and the little terminal tendon. Oh, is this going to be kind of loud? I didn't think this through very well. So you might have this terminal tendon that's right here, and it gets jammed and somehow it gets torn. Now there's two ways. It's a soft tissue and that little tendon is torn, or it could be a bony mallet finger where what it means is that piece of bone was broken. Now sometimes the prescription is going to come to you like, oh, it's a mallet finger. So you have to figure out whether this is a bony problem or just a soft tissue problem. So this one came in like, it actually wrote like it was a distal phalanx fracture, and then she had a pinning. So if you don't know for sure, and this is what happens a lot of times in outpatient settings, you just don't know for sure if it was a terminal tendon issue as well. What you're doing is you're looking, she had a pin. She had the pin in for 6 weeks, I believe, and the pin was removed a week ago, and now she's starting in therapy. And one of the things that I was telling my therapist, as I talk my therapist through these kind of problems so that they could become more independent with their thinking and how they're thinking through these sort of problems. If you have someone who's coming in just initial evaluation, you're just looking at motion, and you're looking for some of the nuances of that type of injury. So one of the most common things of a mallet finger that you're looking for, I'm gonna probably show you with my middle finger, because if their DIP has fallen, sometimes what happens is they're gonna go into some hyperextension here at the PIP. So you want to make sure you're looking for, are they falling into, this is called a swan neck deformity. Are they falling into a swan neck deformity, or are they just stuck, whether they're stuck in flexion here or stuck in flexion in that DIP? So with this particular case, she had about a 20-degree lag of her DIP. And the difference between a lag and a contractor is if you try to move this knuckle, this DIP knuckle, and you are hitting some resistance, right? And you're trying to push it and and you're pushing gently. You're pushing it gently, and you're coming up, and it's getting a little stuck, and you can't really get it all the way. That's more of a stiffness at the joint. Now, if you're able to push it all the way straight, and then when you let go, that knuckle falls down, that's a lag. It's because you can move it into the full motion, but that person can't keep it there. So in this particular instance, we know that it was a mallet finger, a bony fractured mallet finger, and she had the pins in. It's been out for just a few weeks. The most important thing that you could do first day is know any possible deformity. If they have no deformity, or if they have a mild deformity, or it's already severe, you want to note that. If they're contracted at the DIP, or if they have an extensor lag, because if they have an extensor lag where you push them into extension and then you let it go and it falls, that is a soft tissue problem, and you don't want to do any passive range of motion coming down. What you're looking for is some active motion, and then you're looking for, can they actively extend that DIP as well? So that's one of the major differences when you're looking at a joint and you're saying, oh, do they have a joint contracture, meaning they're really stiff at their joint, or is it more of a soft tissue problem, and you can put them into whatever position, they just can't hold that extension. That's called an extensor lag, and that's really, really important in a mallet finger to keep an eye on, because you need them to be able to move that tendon all the way down, and you need to move that tendon all the way up. If you cannot move that finger all the way up into extension, it can continue to fall, and that would not be good. That would actually be a kind of a failure of that surgery, and a lot of times people don't want their finger to just fall and droop, because not only does it hurt and it can get in their way, and it can cause problems later on into what's called a swan neck deformity. So that's my little tip for today. Look out for if it's a joint problem or if it's a tendon problem. I know that sometimes it can be a little confusing when you're reading textbooks and they're saying, oh, like what it might be. Or you might be a little bit confused or not sure about what you can actually do when you first see it. If you're not sure, just don't push on it. Just don't push on it. Just do some active motion, do some scar edema management. You can start with some active motion, because if they're allowed to come into therapy and it's already been at least 6 weeks and the pin has been removed, you know for sure you're allowed to do active range of motion, no strengthening, because it's still a little too early. You also want to monitor how that finger is moving from this visit to the next visit. All right, so I hope that's helped you. So I answered 2 major questions. One, if you are going into field work and into hand therapy field work, what you could be doing. And 2, DIP, mallet finger, and the difference between a contracture and soft tissue type of injury. All right, thank you so much for tuning in. I hope this has been helpful, and I will be around if you guys have any questions as it pertains to hand therapy, what you could do, any type of injuries that you're kind of getting stuck on, you're not really sure what you should be doing. So just leave me a message, and I will be here on next Monday at 4 as well to answer any of your questions. All right, guys. Thank you so much, and next time I will try not to be somewhere where it's so loud.